Good evening, ladies and gentlemen. I hope you can hear me and you can see me. It is a pleasure to have tonight the 19th Master Technique. And on behalf of the Education Committee of BOFAS, I am really excited to welcome our host and you all who have given your time to be with us. So tonight's master technique is on endoscopic procedures in hindfoot, both soft tissue and bony. And I'm really pleased that we have Marc Elkaim, a very good friend and a prominent surgeon in Paris, who is also the secretary of MIFAS and the incoming president of the next Congress of the French Association of Foot and Ankle Surgery in Paris. He enjoys teaching, speaking, and is a gifted surgeon, I believe. And like you, I am looking forward to listen to Marc and see the techniques that he does for minimum invasive surgery, especially in hindfoot tendon transfers, including FHL, FDL, and subtalar joint fusion, which we have selected for this episode of the Master Techniques. Just a reminder, once the Master Techniques episode is over, you will get a link to provide your feedback, and then you will receive your certificate. So without wasting any further time, I would like Marc to take over the stage and share his presentation, and let's listen to him. And we will have, the talk is divided into 3 parts, so we'll have a break after each talk. Like first talk would be on endoscopic subtalar joint fusion, so we can take some question and answers then, and then after that FHL tendon transfer, we'll break up, take questions, and the final will be the last one, which is on FDL transfer. Over to you, Marc.
Thank you, Maneesh. So first of all, I want to thank both of us for the invitation and especially Professor Bhatia for the invitation also. So I will share my screen. That's okay. What happens in this one? Do you see my screen? It's okay?
Yes, Marc, we can see. Perfect.
Okay, so I will talk about arthroscopic subtalar fusion. So I won't talk about indication, just the techniques. So first of all, a little bit of anatomy, because when you do your posterior approach for the fusion, you have to be careful about the nerve and the artery here. They are both protected by the FHL tendon. So the aim of an posterior arthroscopic approach is to check to the FHL tendon, and once you saw it, you're happy because you're protected by you protect the vascular and the nerve here. So the approach normally it's a lateral approach, lateral to the Achilles for the arthroscope, and the medial in the middle part of the Achilles for the instrumentation. So that's why when you go with your arthroscope, first you have to feel the subtalar joint, and then with your shaver, for example, you have to go. You don't see anything. You go through your endoscope, and you slip to the joint. And you have to shave a little bit without seeing nothing at the beginning, but it's very important to be stick to the joint with the arthroscope and stick with the shaver to the arthroscope to avoid a tear of this part, or also on the lateral part you have the nerve here, so you have to be stick to the Achilles. So we have two possibilities to do the fusion with the arthroscope. You can do a lateral approach or a posterior approach. So first of all, for the posterior approach. The installation, I have the patient in prone position. It's important to have the toes perpendicular to the floor. It has to be very straight. I always draw a line, and here you can see the calcaneus, the Achilles tendon. You can draw a line from the lateral malleolus to the medial one. It will be a little bit oblique or strictly perpendicular, and it will end 2 centimeters down the tip of the medial malleolar. And your entry point will be just on the line or just a little bit above. The line is strictly horizontal. You don't need any traction. If you use traction, you won't be able to do any gestures. So don't use traction. It has to be very easy to try the joint, and the joint has to move during the procedure. It's very important to see if you removed all the bone units. You always use X-ray, so you need to realize a retrotibial view. That's why the ankle is very out of the table. This way I can turn my X-rays to have the good view. So the usual approaches of what I told you, the medial and lateral to Achilles, and you have to locate the FHL. That's the most important thing in posterior endoscopic. The material I use, it's a standard arthroscope, so it's a 4 millimeters arthroscope. I usually use an arthroclamp because I don't use the tourniquet. I don't like the tourniquet, sorry. So I want to see the thing bleeds. I want to see the bleeding, and I use an electrode because I like to do the hemostasis. This way I don't have any bleeding after the surgery, and I think that the postoperative cares are easily this way. And then you need shaver, curette. I love the smiley scissors. So these scissors, I don't know if you have it also in England, but it's a normal scissor for open surgery, but I love it for arthroscopy. And it's important also to make craters, to do little holes on both surfaces of the talus and the calcaneus to help for the healing of the fusion. You need also a large diameter of key wires. Normally, it's the key wires from the screws. So it has to be more than 20 millimeters key wires, and large screws. They are always cannulated and compressive screws. Usually, I use two screws of 7 millimeters. I put the screw from the heel, ascending and parallel in the lateral view, and divergent in the retrotibial view. So some videos. So here I'm on the joint directly. I have to remove everything. So I will stop a little bit the video. So here you have the talus, here you have the calcaneus, and sometimes the tip of the tail of the talus can prevent you to go inside the joint. So you have to remove it to go inside the joint. And as I told you, I want to see the FHL tendon. I see I move in various values the joint to be sure I'm in the talus, and then I have to fetch to the FHL. The FHL don't fetch the FHL at the level of the joint. If you try to find the FHL here, you can damage the vessels and the nerves. So it's really important to go up to the talus and to go around the talus and to go down on the gutter to find the FHL. So here it is. The talus is here, and then I will go from up. Talus is here, and I will go a little bit down. So when it's really stiff, when you have arthritis, you have a lot of fibrosis. I asked my assistant to move the toe, and we saw something moving on deep inside over there. And then slowly from up to down, I go and I want to find my FHL here. You see it's moving. So I saw a little bit, so I go a little bit down. And when I clean everything, to remove it, I use the scissors to remove the tail of the talus. And remove it with a clamp. And once you've done that, you see clearly the FHL here. So now you can clean it. And once you have this, you can start preparing the joint. So I like the scissors because it's a little bit curved. So it's very easy to remove just the cartilage and not to remove too much bone. And the important thing is to clean all the posterior facets. So you see clearly here, you still have some cartilage on deep, so you can do like an ice cream with a curette. It's a very good thing. Like an ice cream, you take it and you can take both surfaces. Then with a hook, you just here it has to be smooth. It's soft tissue here, so you did all the subtalar posterior subtalar joint. It moves, so I can put my key wires. So it's very easy now because from this view, it's easy to put the key wires without the X-rays, just to know you're exactly in the position you want, and then you pull back.
Marc, sorry, can I ask a question?
Yes, sorry. Yeah, tell me.
So Marc, do you not use a burr for preparation?
If I use a burr, no, I don't. I use a burr when I do. Sometimes if the bone is really hard, I use a percussionist burr. But usually with the curette and the shaver, you clean it very easily because it's not a very good bone. So usually you can clean it very easily.
Okay, thank you.
So I have to. Sorry, I have to come back on the video. So I will here. Okay, and then you can see the key wires coming. Will be coming from here more or less. Yes, I have one here. And then I can put the other one would be here. You see the bubble. And then I can put it back and with the X-ray, I push the key wire. So it's easy, less X-rays, less radiation. So split it. For the lateral approach, the patient is in lateral position. So exactly the same. I put a knee bar on the tip of the table, on the border of the table, and then I want to be able to flex the ankle and to extend it, to pass the X-rays, and to move the foot where no traction, X-ray, everything the same. So the approach is here. The sinus tarsi will be the optical approach.
Sorry, Marc. When you decide, so how do you differentiate if you want to do lateral or posterior?
Yes, so it's difficult, but if I need to do calcaneus osteotomy at the same time, because the problem is, for example, if you have a flat feet fixed, you can't. For me, I can't correct the flat foot just with the arthrodesis because I can't. I want to have surfaces like that. I can't do something like that to correct it. So I prepare my joint, and once I prepare the joint, I do the osteotomy of the calcaneus to shift and to medialize the calcaneus. This way, with the 2 screws, I can fix my osteotomy and the subtalar fusion.
So, in other words, if there is a valgus deformity, you will choose a lateral approach. But if it's a neutral ankle, then you will use a posterior approach.
Yes, except if you have some calcaneus with the posterior facet is really vertical like that. So when you will be from the posterior approach, it's difficult to go all the posterior approach. So I keep the lateral one because on the lateral one, it will be easier to come from the lateral. So my two indications for the lateral approach is the verticality of the posterior facet, and if I need to do an osteotomy of the calcaneus.
Correct. But the verticality of the talus will be in pes planus anyway. The talus goes down, plantar flexed anyway.
Yeah.
Thank
So
you.
so the lateral approach, the little video, so you will have another view. So here is the posterior part of the subtalar. I have my instrument here, and the anterior part would be on the left side of the image. So I start cleaning the joint. So the joint, you see it clearly. And as I saw you before, I use my smiley scissors because very nice. I can just remove the cartilage. You see the limit between the cartilage and the bone. And I can easily remove it. So you have to think you're from lateral to medial. Here you can see, I don't know if you saw it, the ligament here, which is the end of the posterior facet. And I need to remove all the cartilage, and you will have more space because you come from lateral. You remove the cartilage, with your endoscope, you can go more deeper, and then you see the FHL. It doesn't move. You see, the subtalar doesn't move, the FHL doesn't move. It means I have to remove more. It has to be very, the subtalar has to be very flexible. And here you see it like a synchondrosis, and with the curette and the scissors, I have to remove all these parts. So it's more difficult when you have a synostosis or a synchondrosis of the medial part from the lateral. It's because you are at the end of the instrument, so it's very deep. So it's easier from the lateral approach, but you can do it. And with the curette, you remove it. And once you remove it, you will see that the subtalar joint can close itself. And it means you will have good fusion. Then you can do craters to help the fusion. So you see now the space is smaller. You can move it. You can move up and down. It means it's really, really free. And with the curette, I do little holes on both sides to help the healing. And then I put the key wires like before. One more anterior here and the other one more posterior. Would be come here. So you have the two key wires, you can push back and put the screws in the good position. So that's why I told you, yes, coming.
So sorry, viewers, we agreed, me and Marc, that we want to make it more interactive, and we are going to talk about various queries that might arise. And I'll take all your queries when he's finished this presentation. So Marc, at this point, I would like to ask you two questions. Number one, say for example, somebody is a beginner and he wants to try endoscopic subtalar joint fusion. In your opinion, which is easier, lateral approach or posterior approach?
Posterior.
Good. Thank you.
Definitely posterior, because lateral approach, you have to prepare the joint from lateral to medial. At the beginning, first, it's difficult to see if you're really in the joint because it's not a view you're comfortable with at the beginning. So you have to find the joint. Also, the approach with the shaver just next to the fibula. First you do it with the needle, and sometimes to find your good angulation can be difficult. With the posterior approach, you don't have this problem. You just do your two landmarks to do your arthroscopic and your instrumental. It will be easier. You will find the tendon. You will find the joint. The only thing is you have to careful about the FLTL. But once you've seen it, everything is done. You just have to remove the cartilage. And when you're a beginner, it's much more easier to begin with an arthrolysis, with a fusion, because if you damage the cartilage, not a big deal. It's the aim of the surgery. So I think to start with endoscopic and arthroscopic procedures, the fusion is the best, really.
Yeah. And you talk about the lateral approach. One of the indications questionable is coalition, talocalcaneal coalition.
Yes.
So can you use the lateral approach for talocalcaneal coalition?
Yes. Because while you are on, I didn't put it here, but when you are on the lateral one, you see perfectly the ligament on the anterior part. You remove this ligament, and then you go through the talonavicular, and you can prepare the talonavicular joint from the lateral approach. So when you want to do a double fusion, it's very easy. You can do the subtalar fusion, anterior, posterior, and then prepare the talonavicular joint. It's difficult when you're not trained with the arthroscope, but when I have to do that, I do lateral approach also. Yeah.
Thank you, Marc. Carry on.
So here you have, so it was a flat foot, and you see, so the osteotomy of the calcaneus, which is, you always do a chevron for the medialize. You see the medialization, you see the two screws here, and you see the divergent screw on the retrotibial view. You can see that there is a lot of force on the calcaneus, because you see a little bit, this one is bended a little bit, the screw is a little bit bended. But then after you have a perfect healing, you don't see the calcaneus osteotomy, and you have a perfect alignment of the hindfoot on the front view with the weight bearing. So it's so easy that with the posterior approach, you can also do a TTC fusion very easily, because you're here, the subtalar joint is here, you go a little bit up, and you can prepare the tibiotalar joint. You can prepare the two gutters very easily from posterior side. So as you are in prone position, you can put a nail, and you do everything in mini-invasive. You put the nail, you do the preparation of the two joints, and this way you just have to turn, because normally you put the nail on the supine position, but in prone position you can perfectly put the nail in the same way. It's very good technique also for that. I ended with the fusion.
I think, Marc, I've covered all the questions, and there was one question from the audience just asking the same thing which I had asked, which is indications for lateral and posterior, but you've already covered. So in interest of time, let us move on to your next talk, which is endoscopic FHL transfer.
Okay, so the FHL transfer. The principle is to put the FHL just next to the tendon, the Achilles tendon, normally for chronic rupture. I know that some people do this transfer for acute rupture. I don't do. I do it for 1 month. For me, it's chronic, so I do the transfer. And it's very important to lower the muscle, the belly muscle here, it will be here, to lower it near the calcaneus and in front of the rupture. because if you don't do that, you won't have good results of the transfer. So you have a good article here. Everything is described, the technique. You can read it. It's a prone position, exactly the same as the posterior endoscopic. In this article, they do a third portal in the middle to do the tunnel. I don't. I will tell you why, but I prefer to keep my two portals as I showed you before. So that's the installations. Sorry, oh, I have to start now. You have the lateral view, the front view. It's a straight line, so just above the line. And the aim, you have the subtalar joint here, the FHL here is to find the FHL. It's the same brushing. So I use a lot of the electrode to do the hemostasis and to prepare everything and to avoid the bleeding. I will find the FHL is here. And the most important thing, one of the most important, is to release the FHL proximally. Why? Because if you keep all these parts just in front of the FHL, this little retinaculum, you will have the FHL stuck in the front part, and then you will put the FHL on the calcaneus, and you will have a Z effect of the transfer, which is not very useful to have a good strength after the surgery. So you have to remove all this part to have everything free on the proximal part. And with the arthroscope, it's really easily to go very up of the tendon. I don't want anything, and I want to release all these parts the more I can. Then I go up, I'm up, the belly is here, I'm on the belly, and then I can move the FHL. And then once I did that, I do the release of the gutter here. And this way, this will help me to move the tendon and to cut the tendon. While everything is okay, I put a lasso loop on the tendon from medial to lateral. I keep it here, and outside I put the two stitches into the loop. And this way I can ask my assistant to pull the tendon, pull out the tendon. So the loop is here, and I pull out the tendon the more I can, and I flex the arch. And then I have two possibilities. I can cut the tendon in the gutter with the electrode. Always you have to see the electrode, the medial vessel are here. So always the tip of the electrode are medially to laterally, sorry, to avoid the tear. And I cut slowly the tendon. My assistant is pulling out, and I keep seeing some fiber over there. Okay, I can push, and I can cut it. And once I cut the fiber, yeah, tendon is free, and I can move it and pull it out. So I pull it out. When I pull it out, I have the lasso loop here, and I keep the lasso loop. I don't remove it, and I'm start lassoing it. I use a fiber loop, whatever you want. But the problem is here. You see, sometimes when you do it, you can have two parts of the tendon. It can break himself a little bit. So what I do, I keep my lasso loop. I would turn. Oh, sorry. Oh, it's funny. Sorry, because I turned, I might click the wrong thing. Sorry, really sorry.
That's okay. No one. There's revision.
It was just before. Okay, yeah, this image.
Yeah.
So you see, I keep the lasso loop, and I reinforce with the fiber loop just here. This way, I can't break the tendon because I have my loop here inside. You understand what yeah? It's clear? Okay. Once I did that, I keep it like that. And I go on the calcaneus. I have to turn my optical to have the view through the tendon. So here it was a patient who had a previous surgery, open surgery, and he had a rupture years after. So that's why the Achilles tendon is really stuck to the calcaneus here. It's not like a normal calcaneus. You see here the calcaneus, the tendon is here, a little bit stuck. Normally you can pass easily at this level. Here it's a bit stuck. And the most important thing is to find the middle of the calcaneus. That's why I use a needle from outside, because it's very easy to part the middle of the calcaneus from outside. From outside, I part the middle of the calcaneus, and then I will check inside where I am. So this is the middle of the calcaneus. So I want the tunnel from the middle, but I want the tunnel from medial to lateral to have the variation effect of the normal Achilles. So I prefer not to do a straight tunnel, but a little oblique from medial to lateral. This way I put my drill pin next to my needle, so I'm just next to the middle, and I pass the two cortex and the skin on the plantar part. So you'll see here I have my needle, optical part, and you see the obliquity of my tunnel, which leads to a variation also of the calcaneus as the Achilles does. And after I have to drill, so I normally drill 5.5 or 6 millimeter. It depends on the tendon I size first. And I do a complete tunnel, and then you have to clean this part. Really important to clean this part, because if you don't clean it, it would be difficult to go inside with the tendon. It seems to be not a very big thing, but it's really important. And then when you did this, you pull everything in, and you pull the tendon in. So here you see my loop is here. You see the muscle belly here is coming down, almost on the calcaneus. And I can pull it a bit more, but I don't pull more because I want to push a nitinol guide to help me to put the screw, because it would be sometimes very difficult. Once I have the nitinol guide inside, I can pull more, and you see everything going inside. The muscle belly is next to the calcaneus. So I'm happy when I have this image. I know everything will be okay. So then I put the screw in the nitinol guide. So sometimes it's difficult to see the screw because it can be just behind you. So you have to feel it, not to see. Sometimes you can see perfectly. Here I will show you the screw. So I'm a little bit put the screw in. I have the screw. The tunnel is here. Sometimes very hard. So if it doesn't go like here, you have to tap with a hammer. And once you tap with the hammer, it's okay, and you can screw it. So that's the final view. You have the subtalar here, the calcaneus. The tendon is just next to the transfer. So that's cutting the tendon with the electrode. The other possibility you have, if you have scissors, you can with endoscopic scissors, but I don't have. So I use a beaver. So exactly the same. I ask my assistant to pull it out, and with a needle, I just check in the gutter here. Okay, I just put the needle here, and then I will pass my beaver, and I turn. It's very important to do it with a beaver and not a normal knife, because we cut everything in the middle part. And you will use the tip of the beaver because it's round, but it's very shaped. The tip of the beaver. And under endoscopic control, you can cut slowly the tendon, and you stop here, and you go from the other side to be sure you don't go medially, and you ended the tendon. So you have the perfect cut of the tendon here, and the rest is exactly the same procedure to do the transfer. So that's an example. It was a professional basketball player, and he has a rupture. He had a first operation with tenolic, which was I don't know if you have it in UK, but it's percutaneously, and they did it with ultrasound to be perfect. But he had a rupture, and I did at 6 months. Yes, at 6 months I did the transfer. So you see here the transfer can be a little bit more posterior. That's right. It's a bit anterior, this one, but it works because the belly muscle is in front of the rupture, and you see here the big gap you had in pre-op, and after 5 months you almost have a healing of the Achilles tendon. The AFL also is coming wider, more thicker, and if you do an MRI after it, it's very a big thing. So the magic of the transfer, the postoperative cares are really good, and he walks normally at 6 weeks. He can go on his tiptoes at 3 months with the 2 feet, but not with 1 foot, but okay, and he could return to sport at 5 months, which is really good, better than with a Achilles rupture. So that's true. The outcomes are very, very good. Any question?
What's your post-op rehab for endoscopic FHL transfer?
So I put them in a long boot. I use the Vacoped boots with Equinus. I put the Equinus of the Vacoped as I am in the OR. So I put it in the OR. Usually it's 2. You have 1, 2, 3 on the Vacoped. It's number 2. And then they have full weight bearing with the Equinus of the Vacoped. They can walk. Normally when I see them at 3 weeks, they are working with the Vacoped without crutches. And I start, I tell them to decrease the Equinus 1.5 each 3 days. Normally at 1 month, 1 month or 5 weeks, they can walk with sneakers. And I start rehabilitation at 3 weeks, but in the motion of the boot.
That's perfect. Thank you.
No more questions?
No more questions at this stage, but we'll probably get some more questions after this talk.
So now the FDL transfer. So I never do FDL transfer alone. I always do with a calcosteotomy. I do it percutaneously. So I will show you also the calcosteotomy because it's part of the surgery. You have to do first the calcaneosteotomy. I do first the lateral position, and then I pass the patient in supine position to do my transfer. So normally it's not a big deal because they are under local anesthesia, so they can turn themselves. I don't have to do another everything sterile. It's just it turns around. It's okay. I use the X-ray and I draw. I do all my drawing. So I do always a chevron osteotomy. Why? Because I want to be more powerful on the osteotomy. It's not just a translation, it's also a rotation of the calcaneus. And it's easier to have it with a chevron because mechanically you have a shape like that. So you can turn here, you have a rotation. If you do a flat cut, it's more difficult to turn because more unstable. And it's easier because you have a triangle and you can move the triangle. So I always draw, you have the osteotomy, which is the chevron here. Here it could be my entry point, and then the two screws. I draw also the screws because it will be easier for me and less X-rays. The material I need, the beaver percutaneous kits. I use a 3 by 20 millimeter burr. The motor has to be a high torque slow speed motor, like all percutaneous surgery. And I use a compressive candidate screw. I would use a 5 millimeter and 7 millimeter. I can use just one because it's a chevron, but I feel more comfortable to use two. And I use the 5 millimeter on the upper part because it will be more on the level of the Achilles tendon, and I prefer to avoid a big screw on the tendon. I prefer a small one, but you can put 2, 7. It's not a big deal. So the video here. So I have my incision. I do the dissection with a clamp, with a mosquito clamp. I keep it open, and when it's open, I put my burr inside. It's very important. So I do a tunnel first, and I will orient the tunnel lateral to medial, but posterior to anterior to have a little shortening effect of the calcaneus. It will be easier to move it. First cortex, I do the second cortex. When I do the second cortex, I go back and I do all my cutting here on the lateral part, upper lateral part of the calcaneus. And once I did everything, I go back on my tunnel, I go the medial part, and I use my first cut as a guide to cut the medial part. So that's the real motion. It's not, it's really quick to do it. So once you've done this, you do exactly the same for the lower part. I go on my tunnel and I do the lateral part, so I'm right-handed, so sorry for the view. And then I go back on my tunnel and I do the medial part of the lower part of the calcaneus. And once I did it, it has to move very easily. 2 fingers, and you have to move it very easily. Then I put a thing, whatever, to rotate it and to control this way. I go out, I have my heel out of the X-ray, and you see it moving very easily. And I put in the bone. I ask my assistant to keep it the forefoot. This way I can push on the hind foot, rotates, and I have my mark, and I will put my 2 key wires, and I go back on my X-ray to control the key wire, and normally it's almost good. But it was with arthrodesis, this one. It was a calcaneus and arthrodesis, but it's exactly the same thing. And then you put the other key wire, and this way you have perfect view. And you do the lateral view this way to be sure. Normally you have this when you put the screws, you have the translation, rotation of the calcaneus, and you have this shape. You can also lower it if you want. If you want to lower it, you need to do your fixation in plantar flex to have more mobility on the Achilles to avoid this to go up. So then you switch to supine position, and you have to do the landmarks for the FDL transfer. So that's the most important thing of this video. It's the landmarks. If you do well the landmarks, everything is okay. So you have the tip of the medial malleolus. You have the navicular here, the tip of the navicular, 1 centimeter underneath, and you draw a line from this point to the other one in the middle. So normally it's almost you feel the tibial posterior. The tibial posterior is more anterior, just next to this line. It's here, and you're just posterior to the tibial posterior. And the middle of the line will be your endoscopic approach. And this point, 1 centimeter down the tip of the navicular, will be your instrumental approach. The material I use is the instability kit I use. So I have everything inside. So the passing drill pin. Normally I drill the navicular 5.5 or 5 millimeters. It's very rare to use a 6 millimeter because it's not a very big bone. I use the nitinol guides. It's very important because it's easier to push the screw. I use a swivel lock, fiber loop 0 I prefer, and exactly like the FHL transfer, I use the both stitches, the green one also to take my tendon. Standard arthroscope, shaver, no tourniquet, so electrodes, exactly the same. The landmarks I told you, it's once again, tip of the malleolus, 1 centimeter down the tip of navicular, middle optical portal, and this point would be your instrumental portal. When you go inside from this point, you have to aim the base of M5. Really important. And while you aim the base of M5, your endoscope will be stuck inside the foot. It would be okay. If the endoscope is moving, you're not in the good position. So you do the incision of the skin only. That's why I told you you have a jump sensation. You will see it, and you can locate at this time the FHL and the FDL. Both tendons are here because you're just proximal to the Henry knot. So sometimes it can be difficult to know who is who because they are attached on the Henry knot, and sometimes it can be difficult. So you have to be careful about this. You do the lasso loop. You put it out. You do the section out of the patient, and then you lace. You do the lacing, and you do the drill pin on the navicular from plantar to dorsal, and you pass your transplants from plantar to dorsal. So you don't have any length problem of the tendon because you take the tendons from here. So to go here from here, it's not a big deal. So the tendon here, it's always the good length. But if you don't have the good landmarks, sometimes they have people you think the navicular is here, but have the very big flat feet. You have a prominence more proximal. If you take it here, it will be short. So now what I do, because after I did more than 60 patients like that, the problem is once you're very comfortable with the technique, you think you can do less X-rays. But the one I always do is when I do my landmarks, this point, the instrumental point, I check it with the X-ray to be sure I'm just next to the navicular. Because if I'm more proximal, I will take the tendon more proximal, I won't be able to do my transfer properly. So little video. So here it is. So you have, I do the incision of the, here on the portal, the optical portal. And you will see I put my camera and it has to go through the base of M5 and you see the camera stands itself. And then I Now I do the other portal at the same time to be more quicker. And then I do the other portal here, 1 centimeter down. So in big flat foot, in a big flat foot, it's really plantar because the navicular is really plantar. So you're very plantar. You do your incision with the mosquito clamp, and then you go inside, and you see immediately, almost always, the tendon here. So you have to open all this sheath to see clearly the thing. And you see the both tendons. So if you see carefully, this one has an obliquity and this one is more straight. You see, it's not exactly the same. So you have to check with the toe, and here, when you move the big toe, both are moving. So you have to clean between both of them and then pass the lasso loop. Normally, the more medial is the FDL. If you just see one tendon, go a little bit more medial with the arthroscope because perhaps you passed through the FDL. And if you just see one tendon, it's because you are the FHL. Then you go out with the lasso loop. I put a mosquito clamp here, and I check before cutting. When I move the toe, it moves. So I cut it. So what I do now, because with my lasso loop, it can be a little bit sleepy on the tendon, and the force of the tendon here, it's huge, really, because as you don't open all these parts, as you do in open surgery, as you don't open all the retinaculum, the tendon wants to go up. So what I do before cutting now, I take one wire and I do another loop, and I do a knot to be sure it won't move. And then I cut it. And when I cut it, I prepare it. And then, so normally I do the lasso loop, and then from plantar to dorsal, I check with the X-ray. And I do a complete tunnel. Then I can pass my tendon very easily. Side. So it was a cadaver here, so exactly the same, almost. And you see, even in the cadaver, it keeps you have the foot in equinus and varus, and then you can put your screw inside. So in the normal life, I use a needle guide because it can be difficult to put the screw. And then you see it fits very well, and you have this position. You can have the screw, the tendon is here, and when you do the dissection of the cadaver, don't do this in real life, of course. And you have the transfer here, the screw is here, the transfer is here, and you see that the tibial posterior is really relaxed, and the other one is really tense. So it's really, really powerful. So it's so powerful that when I did in real life, I had better results when I did the surgery. And why? I think because as you don't open all these parts, you still have the pulley effect of the tendon, and that's why it's another dissection. I did the transfer, and you will see that when you open, you will see the tendon here will go up to another orientation. It goes up. That's what I call the jump effect, because it was like that. So that's why you have this pulley effect, and you have the tibial posterior, which is relaxed, and the tendon, which is transfer, which is really tense. But I think as you don't open all these parts, the tendon has this this orientation and not this one. So it's better than open posterior. In real life, what you can have, it's a very big sheath, so you don't have to be afraid, because if you follow the landmarks I've shown you, you can't do something bad. But if you don't see anything, you have to be confident you open this part, because sometimes the sheath is really hard and the tendon is just behind that. So you remove it with a shaver, vapor, whatever, and then you can find the tendon easily. And I don't know why, but when you have this sheath, the tendon are more free inside. They're not stuck at the other one. I can't tell you why. And you see here, I can easily take the tendon with the lasso loop and the so the after is exactly the same procedure. So a little example, you have these big flat foot with the lateral conflict of the malleolus, and you see after the treatment, and it's I think 6 months after the treatment, you restore the arch, and you have a good correction, and it's functional. Here I did also a lengthening of the Achilles. When I do the lengthening of the Achilles, I just do with the beaver, I cut the medial part here and the lateral part here, and then I push to lengthen the Achilles. I always put them in a cast. I don't want them to wait there 6 weeks, but I prefer to be very careful with that. It's because of the transfer. If I just do an osteotomy of the calcaneus for something else, or for when I do a reconstruction or repair of the ligaments and I do an osteotomy of the calcaneus, I leave them weight bare. But for the transfer and everything, I prefer to avoid weight bearing. Thank you. I finished.
Thank you very much, Mark. So that was great, actually. So many visuals, so many videos, um, lovely insight, Mark. Um, there are few questions which I would like to present you now. So let's just continue with the theme of tip post. So somebody has asked about the source of pain. So for example, they are saying it's advanced tibialis posterior disease. And if you don't do anything with the tibialis posterior tendon, like excise it or not, then will it not continue to cause pain? Could it be the source of pain?
I can tell you that I never excise the posterior tendon, the tibial posterior tendon. All the patients I treated, they can have pain somewhere else, but they don't have pain on the tibial posterior. They can have pain on the calcaneus. Sometimes the screw can be a mess, or you have to remove it. Okay, but the tibial posterior, they don't have pain. They don't have pain after the transfer. So I think it's exactly the same procedure with the Achilles. When you do your transfer, you have a healing of the tendon. I have MRI also, and you see the perfect healing of the tibial posterior. I don't put it here, but it's exactly the same that the Achilles. You have a perfect healing of the Achilles, and with the transfer here, you have the perfect healing of the tibial posterior.
Yeah, no, I agree with you. I think also, as you showed, the tibialis posterior becomes redundant, isn't it? It's elongated, so it's not functioning anyway.
Yeah,
Yeah.
it's I call this a chewing gum rupture. It's not just an elongation. It's ruptured, but it's like that, like a chewing gum, and that's it.
Yeah, yeah, agree. Um, Another person has asked a question about the spring ligament. So your technique, obviously, you've just talked about FDL. They are saying, what about the role of spring ligament?
Yes. So I know there is Donata Chevlinkas who did who used my technique to do the FDL transfer and added a spring ligament reconstruction with a fiber tape, with a suture tape, well, with the taping, putting a screw in the navicular, in the sustanticulum tali, and then from the same screw of the navicular, you put the two bundles down to up. You can do it with the technique if you want. I really don't think it's necessary because I did it open before. I think when you do it open, you have to do it because you're opening everything. And as you're opening everything, you have to tense all these parts. When you do it endoscopically, I can't tell you why how it works, but it works because you have correction. That now I do these techniques since 3 years. I think in 3 years I would have some issues on the flat foot, recovering flat foot in 3 years. I didn't have that. Sometimes it's not perfect, the correction also, but all the techniques are the same. You don't have perfect correction. But I don't see relaxing. I don't see that what I done moved with the years. So for me, it's really as you don't open all the retinaculum and you don't open all the sheath as you do open, the strength of the FDL is more efficient than open. That's why I don't do now the spring. If you want to do it, you can do it. But I had some people when I did it open with the spring ligament repair, they were painful on the spring ligament repair because it was too tight. So I don't have this problem now. So, but you can, but I don't believe it's necessary.
No, fair enough. But I am hoping that you believe that you do a calcaneal osteotomy at the same time for,
Yeah.
yeah. What about cotton osteotomy? Do you do, when you're doing calcaneal osteotomy and the FDL transfer, do you do cotton as well?
No, no, I don't do cotton because when I want to do is when I do everything, I think a big part of the thing is the calcaneus osteotomy because I can lower, I can rotate. When you rotate, it's not just a translation, it's a rotation. As it's a rotation, you have if you do the geometry of the foot, you have a lengthen of the lateral arch because you when you do a drawing, you see it, you lengthen the lateral arch. So you have this effect of lengthening the arch, lower the calcaneus and medialize. So I don't need to do the cotton osteotomy. I think the FDL transfer is, I think you have a part of dynamic in the flat foot. I treat the bony gesture with the calcaneus osteotomy and the dynamic part with the FDL transfer.
And you think when you tighten the FDL, then that helps in restoring the arch, so you
Sure.
don't need. Yeah, yeah, fair enough. Um, Another question about coalition. So somebody's asked, do you need to take out the coalition, or can you just do a calcaneal osteotomy? Do you
When
believe
there
in,
is a yes, when there is a coalition, I do fusion.
you fuse always?
Yeah, except in children. In children, I remove the coalition. In adults, I fuse because I will have bad results. Not because of this technique, but normally the subtalar is not functional. It's stiff, so I fuse it.
So you don't believe in the theory that the biomechanics, if you improve them, do a calcaneal osteotomy, then pain will improve. You think you should fuse a coalition in adult?
Yeah, I prefer to fuse it because I've seen some patients from other surgeon and always what I've seen it's okay, I didn't see all the patients, and I have a recruitment with the probably the worst thing of my colleagues, but um, when they had in adults the removing the coalition, they were very painful, and I did a fusion. So I think it's not a big deal to fuse a joint which is not mobile. So I just fuse it for the pain.
Fair enough. No, I take what you're saying. I understand where you're coming from. And then one last question before we end this evening is about your fusion technique when you're doing subtalar joint fusion. Do you just prepare and fuse the posterior facet, or you do anything to the other facets as well?
No, just the posterior facet, except if it's a revision. If it's a revision, I do posterior and anterior facet. But if it's a primer fusion, I just do the posterior facet.
That's brilliant. I think, in the sake of time, uh, obviously it's 1 hour. It's 8 past 10 where you are, Mark, and thank you so much. One thing I would say that the visuals were very impressive, and this is the whole point of Master Techniques, that videos carry much more meaning than just listening to slides or
Yes.
looking at the slides. And the second thing I would say, the number of people who started in the beginning are the same towards the end, which means that people are really engaged. They have not just left. So they have. I'm sure they've enjoyed, and we'll get the feedback. So, guys, when you receive the link, please send us the feedback so that we can improve. But Mark, on behalf of BOFAS, I really want to thank you once again for this excellent presentation. Your surgical skills are a lot better than mine,
No,
or so
no.
thank you for teaching us your techniques and the insight into what you can do with small incisions. Thank you so much. Have a great evening, everyone. Good
Thank you
night.
very much for the invitation.
Take care. Okay. See you later. See you later. Bye bye.
Bye bye.